I would like to thank them for my participation as a speaker on this very versatile topic, which is a common problem, not only in general health, but also regarding the fertility. That is obesity and IVF outcome. Obesity, it is a worldwide concern with detrimental health effects, including the decreased fertility. Obesity has its effect on IVF by hormonal changes, which affect the health and viability of the eggs and uterine lining. According to CDC, 1/3 of the women, American women, and according to WHO, 23% are overweight in the reproductive age group. According to recent meta-analysis, live birth rate in these women undergoing IVF is statistically significant and is decreased by 0.85 compared to normal weight women. When we talk about BMI, what is a normal BMI? It is a weight in kilogram per meter square, and the normal BMI is 19 to 25. 25 to 30 is overweight, and from 30 to 35 is grade 1 obesity, 35 to 40 is grade 2 obesity, and more than 40 is grade 3 obesity. What are the causes of obesity? It could be genetics running in the family. It could be PCOS, polycystic ovarian syndrome, hypothyroidism, food inactivity, consuming much food but not burning it. The environment around you also has an effect on the sustaining of the healthy weight. Health conditions and medications. If you have some health issues, then you won't be able to maintain your weight, and if you are under the effect of certain medication, then obesity again is a problem. Everyday life stress, emotional factors, and poor sleep also contributes towards obesity. Coming towards the first cause, hypothyroidism. Its prevalence is 2 to 4% in reproductive age group. It causes heavy periods, anemia, and amenorrhea. Underactive thyroid, body will use less energy and more will be deposited in the form of fat, leading to obesity. Meta-analysis has shown that obesity was associated with 1.8-fold increased increased risk of developing hypothyroidism with both overt and subclinical types. After treatment, 80% will get pregnant in 6 weeks to 1 year, and that was a cross-sectional study in DMC. According to research, thyroid antibodies, they had an association with reduced pregnancy outcome, and in these cases, low-dose prednisolone helped with thyroid and IVF success. So this is a picture which is showing how hypothyroidism affects a female. She will feel cold, there will be swelling at the neck, could be fatigue, mood and memory changes, high level of cholesterol, slow heart rate, weight gain, constipation, dry skin, hair, could be hair loss will be there, brittle nails, and menstrual changes. Sore muscles and joints will be there. Then we come to the second cause, polycystic ovaries, which is very common nowadays. 1 in 5 women, they have this problem. And this is a major endocrinopathy among reproductive age group women. It affects 4 to 20% of the women of the reproductive age group. These women, they present with the clinical features, menstrual irregularities. The first is the infrequent cycles, and then there could be amenorrhea. The cycles are after 2 months and 3 months. There could be hyperandrogenism in the form of acne, hirsutism, temporal baldness, and there will be like male distribution of hair on the lower part of the body and back. There could be skin changes, deposition of fat on the upper part of the shoulders. It could be obesity, elevated androgen levels, it could be testosterone, androstenedione, etc. And if you do an ultrasound, there will be pearl necklace appearance, presence of greater than 12 follicles, which could be 2 to 9 millimeter, and the ovarian volume is also increased. We see this picture, which is typical of necklace appearance. If you see all these follicles, they are not ruptured and they are in the form of just cyst. And this is the thick stroma in the polycystic ovaries, which are responsible for producing the androgens. What happens is there is the excessive androstenedione is produced in the fat cells and they are converted into the estrogens. And when the estrogens are more in the blood, they affect the part of the brain which is controlling the hormones, metabolism, and the ovarian function. If we come to the treatment, major part of it I will discuss later, but I want to talk about OCPs. When we give OCPs in the girls with polycystic ovaries who just want to maintain their menstrual cycles, it increases the sex hormone binding globulin and it binds the androgens. And when the androgens are bound, when the woman is taking for 6 months, the acne is reduced, the hair fall is reduced, and the menstrual cycles take place. And once you stop it, there is ovulation and women do conceive as well. Why we are so much concerned about obesity? When we are in an IVF center, we see that they respond poorly to clomiphene. Larger doses of gonadotrophins are required. We attain fewer follicles. Our ultrasound people do see the fewer follicles are there, and we are able to retrieve less eggs. The quality of egg is poor fertilization, and poor quality of embryos. And then, even if then we get embryos, the implantation failure takes place. So, weight loss regularizes menstrual cycles, it increases the ovulation and conception. It not only affects our conception, it has its effect on the ongoing pregnancy. So, once we are successful in having a pregnancy, if the woman is obese, she can face miscarriage, recurrent miscarriage, preterm births, stillbirths. The birth defects may be associated like cardiac or neural tube defects. There will be gestational diabetes mellitus. Women can suffer from preeclampsia, eclampsia fits, and this is one of the cause for maternal mortality. The blood can get thicker and there will be thrombosis, pulmonary embolism, another leading cause of maternal mortality in the UK. There are poor surgical risks, complications of surgeries are higher, and anesthetic risks. So reducing body weight reduces the risk, and small changes leads to big success. Research in this field has shown, according to American Society of Reproductive Medicine, higher the body fat percentage, it affects the fertility outcome. So obese women have significantly decreased LH levels, and it has a specific sensitivity of 62% and specificity of 86% for IVF failure. Fertilization rate in obese women are lesser as compared to the normal. Obese women have a pregnancy rate of 15%, whereas normal weight women have a pregnancy rate of 33%, and the p-value is 0.01. So, conclusion of one of the study was that despite equal amount of recruited mature oocytes, obese poor ovarian responder women had decreased fertilization and clinical pregnancy rate as compared to the women who are normal weight. The ovary makes the estrogen and fat cells stores the estrogen. When the body recognizes that the estrogen is overloaded, it behaves like the woman is pregnant and ovulation doesn't take place. This is the same science behind OCP action. Excess weight doesn't only affect the women, but it affects the man as well. If a man is obese, more than 28 BMI, the sperm production is reduced, there is decrease in libido, testosterone levels, and as we have spoken about, there is erectile dysfunction. Harvard study found out that obese men are 42% more likely to have low sperm count, and among them, 80% are more likely to have no sperms at all. The scientific reports in 2016, men with higher BMI have lower fertilization rate, decreased good quality embryos, and clinical pregnancy. Mean STL is lower, there are high reactive oxygen species, high oxidative stress, increased DNA fragmentation of the sperm. PCO is obesity related, and any time PCO patient gains weight, her menstrual cycles become irregular, and the ovulation doesn't take place. And when they lose the weight, the cycles become regular. 80% of the ladies who suffer from PCO, they are overweight. Obese women, they are less likely to get pregnant. IVF pregnancy rates are lower in obese women. If we see the age-adjusted ratio, live births are reduced by 37% if the BMI is between 30 and 34, and 61% if BMI is 35 to 39, and 68% if it is more than 40, as compared to a woman with a normal BMI. There is also evidence that increased BMI is associated with impaired ovarian follicogenesis, abnormal oocyte mitochondria, and poor granulosa cell metabolic activity. Obesity has also been correlated with higher levels of insulin, androgens, estrogens, and leptin, which in the follicular fluid may contribute to poor follicogenesis, poor cumulus cells function, and subsequently poor oocyte quality. There was a study in May 2021 when they realized that conception was not taking place. They have found out in this cohort study that there was no effect of BMI on embryo quality, and they were stressing that one should find out the other causes why the conception doesn't take place. For clinicians, there is sometimes difficulty in decision making when the woman has not much time. She is older, 36, and she is obese as well. And according to one of the study in PubMed 2010, Mr. Pandey said that the effect of BMI was strongly influenced by the age. Journal of Assisted Reproduction and Genetics 2021. Obesity is also associated with detrimental effect on oocyte and endometrium. In ovary, cytokines play different roles in follicogenesis and display a relationship with obesity and inflammation. At cellular level, obesity induces lipotoxicity, leading to increased level of pro-inflammatory cytokines in the systemic circulation. These cytokines and adipokines, they elicit changes in the follicular fluid, which is supporting the oocyte. There are 3 more studies which have similar outcome, and this is at cellular level, obesity affects the RNA sequence, which affects the inflammation and lipid metabolism in the oocyte gene expression. And there was a science report in 2020, according to them, again metabolism alteration of follicular fluid of obese women affects the outcome in IVF women. And American Journal of Endocrine Metabolism 2019, they are also the same result that obesity leads to distinct metabolism in follicular fluid of women undergoing IVF. So what should be the management? I think it should be a public message and general awareness of maintaining their BMI according to their height. And it's very important because obesity leads to a lot of medical problems. And since its role, we are discussing IVF over here, fertility, it has a great impact on the treatments. Improved counseling and patient communication improves outcomes. I remember from my Bahrain experience that when I want to ask the ladies that you go and walk. So, because after 38 weeks, I want them to walk so that they walk and their muscles are active and they can push during the labor and the labor is easy. So, the patient came to me, or she was smiling while I was working on the computer. I said, why are you smiling? She said, Doctor, यदि कुल्लो मरीज मौजूद फिल पार्क, आपके सारे मरीज जो है ना वो पार्क में, मतलब they are having a walk in the park. So, walk has a good outcome, not only on your weight maintenance, but it improves the circulation, you feel euphoric, and the life becomes more livable for you. The height of ideas that comes to you is through exercise. Safer protocols for PCO patients to reduce the weight. Nowadays, a lot of preparations are available which have L-carnitine, omega fatty fatty acid, minoxidil, and probiotics, which are very effective for PCOS patients, and they claim that the result is available in 6 weeks to 6 months' time. Prospective IVF patients can bring their BMI close to normal. Give them small aims, not larger ones. Small points are reachable, goals are reachable rather than. So if she is 32, weight comes to 30, the menstrual cycles are improved. And if they are 30, they go to 28, even then the menstrual cycle improves. Diet program using 3 to 4 pounds a week, that can be helpful. Exercise, 7% of weight can be reduced if you do 150 minutes walk per week. So each walk takes about 45 minutes. What increase the water intake. Now NHS in England, they don't cater patient above BMI of 30. So they restrict their services to the patients whose BMI is between 19 to 25 or overweight between 25 to 30. Gradual, everything should be done gradually. If you do crash run, it has a detrimental effect. Benefit of weight loss is that if 5 to 10% weight loss is there, the endocrine parameters such as there is decrease in free testosterone, the insulin level decreases, and increased frequency of ovulation. 11% reduction in central body fat improves the luteinizing hormone with normal menstrual cycle. Weight loss can be achieved by lifestyle modification. Lifestyle modification is to get up earlier, go for a walk, have a healthy breakfast, and then like to have a breakfast like a king, and then some snacks in the mid time, and have early like a what you say bagger the night meals, and stop eating before you are full. Do not take drink in between, and try to sleep earlier. The sleeping hours also has effect on the obesity. Dietary restriction, avoid junk food and the food that has more sugar. Physical activity, as I've told you, exercise, gym, whatever suits you or you are comfortable, try to engage yourself in that. And pharmacotherapy with different results. Lifestyle modification can be sustained only by 15%, rest of them is stopped. But there is a positive effect if you do group therapy. There are music, we have different dances, cha-cha and yoga and whatever you feel happy with. You should join a group and try to maintain whatever weight you have lost. Behavior modifications, as I've already told you, and the follow-up is there. In my opinion, as we maintain a diabetic diary, we should maintain a weight loss diary as well. Give them small goals and try to encourage them whatever they have lost and try to maintain it, and as along with that a diet chart should be provided to them. When we come to the pharmacotherapy, glucophage is the drug which is written for PCOS patient right and left. It has a, when we go to the research, it has a mixed view. 850 milligram of glucophage twice daily have no effect on the body weight or menstrual cycle, and the insulin sensitivity despite fall in the total testosterone and body weight. So body weight fat distribution takes place, total testosterone also falls, but there is not much effect on the weight. Their variant to 2019, the Vicro study, 850 milligram daily when the patients were giving, the weight loss was only 2 kg in 1 year time. And CFARS 2013 in PubMed, mean weight loss was 5.8 plus minus 7 kg, and if those who are untreated or don't take any medicine, the weight gain was 0.8 kg plus minus 3.5 kg. When I see my own clinical practice, I see the patients are not very happy. If you ask them, कि हाँ नहीं थी 2-3 महीने के लिए दिल की धड़कन तेज हो गई थी, चक्कर आ गए थे, तो मैं तो आधी ले रही हूँ, and they don't take the full dose. So I don't think so. It's a very popular drug, and it's continued by most of the patients. Then there are other drugs in the market nowadays available. These are the drugs which have different minoxidil, then L-carnitine, and they have folic acid, zinc, magnesium, and they claim this is a drug they claim for PCOS. And according to them, it helps in reducing the weight, regulating the menstrual cycle, reducing the oxidative stress, and help in ovulation. And according to them, one sachet daily, and the results are seen in 6 weeks' time. Next, we go to FibroCal, which is basically a husk, and they claim it to take it before meals, half an hour. It swells in the body, and it's just like medical sleep. It fills the stomach, and your stomach is already half full. So the amount of food you take is less constipation, toxins are released from the body, and weight maintenance is possible. Even it helps in the control of the diabetes as well. Orlistat is not very popular. It will result in the release of GPL, which stimulates the fertility center, but there is a rebound, excessive weight gain, and it can cause liver injury as well. So it's not very popular. Then the next new thing which is in the market is probiotics. They are the friendly bacteria which stimulate the gut, and the amount of mucus is produced. So these fatty acids, they block the spaces, and inflammatory agents, they are not released into the blood. When the LPS is reduced, the brain knows that, and insulin sensitivity is reduced, and the fertility center is stimulated. The patient eats less food and helps in the weight loss, regulation of menstruation, and helps in the ovulation. And again, they are also claiming that the results available in, you can see in 6 weeks to 6 months time, and doesn't need a long-term treatment. When we go to research and see on the other hand, according to a journal, Human Reproduction, April 2020, they have found out in their study, normal weight women were 1,500 and obese were 250. They said that the live birth rate was not statistically different between obese and normal weight patient after frozen thaw blastocyst transfer was done. But I would still say if this is the new thing and frozen thought blastocyst transfers helps and there is no difference in the obese and normal weight, but we have seen in the previous slides that obesity do has its effect on the quality of oocyte and then conception and implantation failure. So I think we have to educate the people and maintain a good BMI so that our treatment is successful. Having healthy take-home messages, having healthy BMI is only one piece of jigsaw. A balanced diet, sleep, exercise, a positive outlook, and reasonable expectation may be just as important. So, optimism is the best way to see the life. When you think positive about the things, things do work for you. And a little change brings big success. That's what I have to say. Thank you very much.
Free doctor's appointment. Call us on +92 320 2233 074.